Welcome back. This one we are going to talk about upper extremity arterial. So this is going to be very similar to lower extremity that we have previously done. This one is going to combine both imaging and segmental into kind of one protocol, one study. In the hospital, they can be done separately or they can be done in conjunction with each other. Honestly, we don't do many upper extremity arterial studies. I would say it's actually kind of rare to do. Students in clinic are only required to get a few of these, so it's not something that you're going to be doing on a daily basis. As always, make sure you're taking lots of notes as the slides themselves are pretty simple and most of what information may be on the test is probably going to be from what I'm discussing. All right, so let's get started. So for this exam, there will be no patient prep. They do not need to do anything prior to coming to the ultrasound department for their scan. The patient will need to remove their shirt. Now for males, I typically just have them remove their shirt and then I will tuck a towel or a sheet across their chest and under their arms. For a female, I do allow them to leave their bra on, and if they were more comfortable, you can have them change into a gown, but again, you're going to have to be like in their armpit area, so sometimes having a gown on just creates it kind of gets in the way. So oftentimes I will just have them remove their shirt and then drape a sheet or a towel across their chest area. Now for this, the patient will be supine with typically their arm across the scanner's lap. So as you can kind of see here, there's a lot of things wrong about this picture, but as you can see here, it kind of gives you the patient positioning. So that's what I was going for. Oftentimes the patient will bring their arm across your lap and you'll scan it that way. Or in order to get into like the armpit region, you can have your patient bring their arm up above their head. I don't personally prefer that method, but I know some sonographers scan that way, and it is definitely an option to try if you're struggling the other way. Now for this exam, you are going to use a linear probe, just as you have before, typically the 9. We do have a higher frequency transducer, the 15, that can be used as well on the radial and ulnar arteries that are going to be a little bit smaller. So that's another option that you can always try to switch to. And then we also have the hockey stick probe that has some really nice features. It's a super high frequency. I think it's at least 18, and it looks almost like a little pencil that you would hold. And we do have one of those in the lab. So you can use that as well for some of those smaller vessels. I don't love the color imaging and the Doppler on it, but it's great for grayscale imaging. So our patient history questions are very typical. We have still the 4 questions that we're always going to ask with any type of arterial testing. So smoking, do you smoke? Have you ever smoked? If so, how long? How many packs a day? You want to make sure you have all that information. Do they have high blood pressure, high cholesterol, or diabetes? And if any of those, you want to know if it's medication controlled. Now, specific to the arms, pain is typically the biggest symptom or reason that someone is going to come for one of these exams. So you want to ask if they've had any pain in their arms. If so, where at? How long? Is it, you could do like on a scale of 1 to 10 just to get a little bit more information. You would also want to know if they've had any previous surgeries on their arms and any history of peripheral vascular disease or other heart or vascular disease. So if they have a previously documented disease or stenosis or something going on in their lower extremities, then again, they're more likely to have something in their upper extremities as well. So you want to document if they have any history of this. Also, don't forget to review the order. You want to check for any previous, that way you can compare. As always, double identify your patient, typically with last name and date of birth, and wash your hands, put on a glove. And you'll go ahead and document all of this patient history on a form or in your tech report to give to the physician to help correlate with your study. Now, I always like to do a little anatomy review just because some of these vessels in the upper extremity and coming off of the aortic arch can be a little confusing. So, one of the first vessels that we're going to scan is the subclavians, okay? So, if you remember from anatomy or even cross-sectional anatomy, if you have taken that already, the right subclavian artery will come off of the innominate, and you can see that on the image over here. The innominate or brachiocephalic are interchangeable terms, so you can use the innominate artery or brachiocephalic artery. So as you can see, that comes up there on the right-hand side. The innominate is that first branch off of the aortic arch, and then it further divides into the right subclavian artery and the right common carotid artery. So you'll see that there on the right side. However, the left subclavian, if you notice, comes directly off the aortic arch. Okay, so in order, we have the innominate or the brachiocephalic, then the left common carotid artery, then the left subclavian artery. Those are the three coming off the aortic arch. The subclavian arteries then become the axillary arteries at about the level of the thoracic outlet. Now, we are unable to see the thoracic outlet on ultrasound. There's nothing, that we can see on the image that says, oh, yes, that's exactly where the subclavian turns into the axillary. What we kind of use on ultrasound, or as a good rule of thumb, is at the mid-clavicular level. So mid-clavicular meaning the clavicle. If you kind of took the clavicle and drew an imaginary line down the middle at approximately that level, and you can kind of see it over here on the right where the clavicle comes across, at approximately that level is where the subclavian artery becomes the axillary artery. Now you can see the subclavian really isn't long. It's not a big long vessel, and the majority of it is going to be underneath the clavicle or very, very proximal towards the aortic arch. That's going to be a little difficult for us to visualize. So whenever you're scanning the subclavian artery, you'll want to stay as proximal as possible close to the clavicle. The axillary artery goes on to become the brachial after the axilla or the armpit. So most of the axillary artery is located underneath or under the armpit, and then it becomes the brachial artery. The radial and ulnar form after the antecubital fossa. So the brachial artery actually splits into two different arteries, the radial artery and the ulnar artery. And this happens just after the antecubital fossa, which is the bend in the elbow. So that kind of space there where the elbow bends and you kind of feel like a little divot and things, that is going to be the antecubital fossa. Now, the radial stays on the thumb side and is going to stay very superficial. So as you're scanning, radial is going to be on the thumb side, and remember anatomical position, okay? Anatomical position is with the palms facing up. So radial is going to be on that thumb side. It's going to be more lateral, and it's going to stay superficial as you're scanning. So you will see it close to the top of the screen the whole time as you're scanning. The ulnar then is on the pinky side or the medial side of the arm. So in anatomical position, the ulnar is going to be closest to the body or medial. The ulnar artery is going to dive deep and then it will become more superficial. So proximally after the antecubital fossa, you will see that ulnar artery dive down towards the bottom of the screen, and then as you get more distally, it'll become more superficial. I'm going to go back to the brachial artery real quick. One of a really nice landmarks to visualize the brachial artery is the humerus. Okay, so the humerus is the upper bone in the arm, and as you're scanning, you'll often see the humerus on the screen. It's going to appear black and shadow out because it's bone, and typically the brachial artery will lie pretty close to that or just anterior. So as you're scanning, I would recommend, if you're struggling to find the brachial artery, look for the humerus, and the brachial vessel should be relatively close to that. All right, as far as scanning, this is very similar, and if you haven't noticed, this is what we do all the time, over and over. We are going to obtain our images at each level in our protocol in grayscale, then in color, and then in color Doppler. Now, I've talked about this before, but make sure when you're scanning, you are thinking in these of layers. So your first layer is grayscale. Make sure you get your image appropriate for that, appropriate depth, appropriate gain, appropriate TGC. Make sure your vessels are cleared out. Print that picture. Then when next you're going to turn on your color. Okay, so that's your second layer. Then you're going to make sure that your color is contained within the vessel walls. Okay, once you get that picture, you print that, then we flip on our Doppler. Okay, our grayscale should be good. Our vessel should be clean. Our vessel should be stretched across the screen. We should have beautiful color fill. Now we're just adding that third and final layer. And once you Doppler, you always want to measure the peak systolic velocity, and you're going to document any areas of stenosis that you may see, whether it's in color or with Doppler and showing an elevated velocity. This is a typical protocol for imaging. We are going to start up high, most proximal and superior at the subclavian artery. Then, like I said, continue down the arm into the axillary region. This is going to be in the armpit. Brachial, we take proximal, mid, and distal. Radial and ulnar. And then we're going to do grayscale, color, and Doppler at all of these locations. Now I added this picture on the right because it's of the subclavian artery. And I wanted to point out this over here on the side. Okay, so you can see this here. That is part of the clavicle. Okay, so when we are imaging subclavian artery, I really want to see clavicle on the superior side of your image or on the left side. Okay, because if we're in long, that's going to be the superior side. So we should see that clavicle on the left side. We should see it shadowing out. You may even be able to pick up some color flow going posterior to that. By seeing that clavicle in your image or that shadow, that is going to signify, the doctor and myself for the time being, that you are very proximal and truly in that subclavian artery. It's a lot easier to visualize more distally, but really once you get past that, you're into axillary. So it's very important to stay superior and basically touch your probe up to the clavicle, and you'll actually see some of that shadow in your image. The subclavian artery can be difficult to image due to a lot of it lying, posterior to the clavicle. So don't get frustrated. Sometimes these are the best images I could get, and just do your best. So this interpretation should be no different from lower extremities. So this is the, triphasic, biphasic, monophasic. So in a normal or multiphasic waveform, we should see that sharp systolic component where it goes up very fast. You are going to see it come down very fast as well. Then you'll see that brief reversal of flow where it actually drops below the baseline. And you can actually see this when you're scanning as well. There will be that quick flash of blue in your color with a triphasic waveform. Okay, that's what you're seeing in color, is that brief reversal of flow that's dipping below the baseline. Then with the triphasic waveform, you're going to see that second forward bound of flow just prior to starting the cycle over again. So what we're looking for or aiming for or really want to see are the top two waveforms. Okay, so triphasic at the top, biphasic there in the middle, that's going to be considered normal for the most part. So either one of those we're happy to see. Abnormal then is going to be that very bottom waveform, and this is what we are going to call monophasic. So oftentimes this is due to a stenosis. Okay, so there's loss of energy. The amplitude overall will be lower. Notice those rounded peaks as well, as opposed to those sharp ones that we saw up above. So there's going to be a sluggish upstroke and downstroke, and those waveforms are just really stretched out as opposed to the ones on top. And then lastly, you may see an occlusion, and this would be no flow, so that you're not going to have any flow on color. When you put the Doppler signal in on there, you're going to have a complete flat line. Okay, so an occlusion would be no flow seen by color or Doppler. Collaterals may also be seen if this is a long-term occlusion. You may be able to pick up on those as well. So the next thing is some scanning tips. The first one is to make sure that you are trying different approaches. So I know as students, when you find, the vessel or whatever it is that you're trying to image, you get really excited and you don't want to move off of that vessel, but sometimes you have to take a different approach to get the optimal image. So your best images are going to come from what you do with your hand, okay? Think of the machine as being like you're fine tuning. If you're not getting what you want with your hand, then we're going to go to the machine and see what it can help with. But most of your manipulations, angulations, things like that are going to come from your hand to produce that best image. So don't be afraid to try different approaches. Don't be afraid to try more medial and angle back at it, or more lateral and angle back at it. It's all about approaches, pressure, less pressure, more pressure, and trying different things with your hand. The more that you can get used to manipulating that probe and being comfortable with that being like an extension of your arm, the better off you're going to be as far as optimal images. As always, you want to start in transverse to find the artery. It's just going to make it a lot easier for you because you'll be able to see the little circles that pop up, and it's just easier to see. If you are starting in a long plane and you are not directly over the artery, you'll never see it. But turning into a transverse plane allows more surface area for you to be able to catch those little circles. And then once you get on it, you can always turn into the long view. Again, make sure that you are staying perpendicular for your best grayscale imaging. So you want to be 90 degrees from the structure that you're trying to image. So very perpendicular for grayscale imaging. And then a slight angle is always best for color imaging. So again, this can be just, a heel toe of the probe to put some angle on your vessel. This could be coming slightly medial, slightly lateral, but an angle is always going to be best for your color imaging. If you hit something at 90 degrees with color on, there will be no color flow at that spot. If you are struggling to get your vessel stretched out, try the doorknob twist, okay? And it's going to be very, very tiny, fine movements. It's not going to be big movements like you're actually twisting a doorknob, but it's that same kind of feeling or approach with your hand. And what you're doing is kind of tweaking that superior and inferior portions of the probe to stretch out the vessels. So if you're struggling with getting those vessels stretched from superior to inferior, wiggle that probe a little bit and use a doorknob twist to stretch it out. Now I did want to hit hard on probe orientation for the subclavian vessels. This is something that can be confusing to students as far as which way your knot should go or your orientation should go with the subclavian. I will likely go over this in class as well in front of you with a probe, just because it can be kind of confusing. Typically, it's very confusing for the right subclavian because you almost have to turn your probe a little bit backwards, and it tends to be confusing. So I wanted to add this image here with a scan of the right subclavian vessels. So as you can see with the probe, it is oriented in a long plane to the body. Okay, so it's oriented in a longitudinal fashion. But what do we see over here on the right-hand side? We see round or transverse looking vessels. The reason for that is because you have to think about how the subclavians lie within the body. So they run in more of a transverse or a horizontal fashion. Okay, think about the clavicles and how they run. The subclavian vessels run kind of in that same parallel, plane as the clavicle. So when I am in a longitudinal plane to the body, I am visualizing the subclavian vessels in a transverse or a short axis. Okay? So if I was scanning, like I was, on this image right here, if I was scanning and I wanted to stretch these vessels out and get them long on the screen, I would actually need to take this superior portion of my probe and twist it this way to the right a little bit, but to the patient's head. So that's the key there. When we are in a long plane or showing a long orientation of a vessel, which direction should our probe be oriented? It should be oriented to the patient's head. So it almost feels like you're going to tip backwards, okay, because you're going to bring it more to the right. But the key is for a long plane, you are going to tip it to the patient's head. Then we always go 90 degrees from that for transverse. So this would be the position or close to that you would want to have for a transverse subclavian scan. So hopefully that is making sense. A lot of students want to bring this part of the probe to the right because we always say, to the patient's right or to the patient's head. But we do it to the patient's right in a transverse plane, okay, not in a long. So that's where you have to think about that. If you ever get confused or struggle, come down the patient's arm a little bit. You know you're going to put the notch to the patient's head that way. And if I slid my probe up this patient's arm, I would have this turn towards the head. I wouldn't flip it and bring this part over to the side. I wouldn't flip it. So if you're ever struggling, start low and scan back up to help you know which way you should orient your probe. The left side tends to be a little less confusing because you are pointed to the patient's head or to the patient's right already when you're in a long plane. Now, even though our orientation with our probe is a little bit different, we would still label it long subclavian when it's stretched out across the screen. So if it looks long on the screen, we are going to label it long. If it looks transverse on the screen, we are going to label it trans. This is kind of one of those times where, the normal rules don't quite apply, but it makes sense if you think about the orientation that the subclavian vessels have in the body. And if you just remember that when long, you always want the notch to be pointed to the patient's head. And then lastly, I talked just a little bit about the hockey stick probe at the beginning. There's some pictures of it up here. Okay, so you can see how small and tiny this probe is. It almost looks like a pencil and you hold it like a pencil, but this is going to come in really handy when doing radial and ulnar because they are so tiny. Okay, so if you're struggling in lab, feel free to get out the feel free to get out the hockey stick probe to scan the radial and ulnar vessels. It's great for grayscale. It's not as great for color and Doppler, but you may be able to obtain some nice images that way as well. Most labs will have the hockey stick probe, so you can use this, out in clinic as well. Oftentimes, a physiologic is also performed with an imaging study, and they are done in conjunction. Now, they can be done separately, but oftentimes they're done together. So this is going to be very similar to our lower extremity protocol. We have, multiple steps and multiple things that we're going to do to complete a full study. Rarely do you have just like a limited study, like on the lower extremities, we had an ABI. Don't really have that on the upper extremities. Typically, you're doing a full, complete study. So the first thing that you're going to do is obtain Doppler signals from the subclavian artery, the axillary artery, brachial artery, radial, and ulnar. So you're going to take your little probe here and you're going to listen at each one of those stopping points and record your waveform. So hopefully you're looking for a triphasic or biphasic, multiphasic waveform. And again, try more pressure, less pressure, angles to get those pretty waveforms. Once you've obtained your Doppler signals, then you would apply cuffs to both the upper and lower arms. So you're going to put one at the brachial area up on the top of the arm, and then you're going to add another cuff on the forearm. And typically we use 10-centimeter cuffs for both of these. Unless you have a larger patient with thicker arms, then you can always bump up to 12 centimeters on the top. Some facilities will have you do PVRs on the arms, some will not. That's going to be, again, very similar to PVRs on the lower extremities. You are going to cuff your patient and the machine will kind of do the work for you. The biggest thing to remember is keeping all of your technical settings the same. We can't have gain, on one spot set at 10 and then on another spot set at 20. We want to compare apples to apples, so you really want to keep all of your settings the same. Then we go on to perform segmental pressures. So you would listen on the brachial and inflate the brachial cuff to get a reading. Then you would do the same thing with the forearm cuff and listen on both the radial and the ulnar arteries. You will also do fingers, okay? So you're going to get pressures on the fingers and calculate a finger brachial index. All of these items will go into a complete upper physiologic protocol. Now again, this is not something that you're going to do frequently, but sometimes for dialysis, with vein mappings, they will do upper extremities. So you should see some in clinic, but it's not going to be one of those everyday studies that you do. So just some common findings, and these were pretty similar to the lower extremity as well. First one being atherosclerotic obstructive disease or any occlusions, blockages, anything that is disruptive to the flow in the upper extremities. So that's, really the main thing that we're looking for. And then the patient may have an acute occlusion as well. I would say this is probably pretty rare, but it could be something that you come across. These are some other upper arterial testing procedures that we can do, and most of these we'll get into next semester, and these are considered specialty clearances for clinic. So you would not be required to complete any of these, but if you see them, you have to complete so many before you graduate, and these ones may be options of ones that you can complete. So the first one is thoracic outlet testing. So we actually put sensors on the patient's fingers and put the patient into different manipulations to make sure that there's not an issue with that thoracic outlet and any pinching of the artery, nerve, or vein. And we'll get into this more next semester. We'll actually perform a thoracic outlet study as one of our open lab assignments. Next one is a cold immersion study, and this is where we are checking for Raynaud's, which is where you can have some loss of blood flow and discoloration to, fingertips. So with this, they actually, as awful as it sounds, submerge a patient's fingers and kind of like up to not quite their wrist, but most of their hand into an ice cold water bath. Okay, it sounds awful, right? And it is. These patients are uncomfortable. They already have issues with cold sensitivity, and then we go ahead and submerge their fingers into cold water. Now, I would say this test is not done nearly as frequently as it used to, but you may come across this in clinic. And then lastly is an Allen's test. This is going to be a test to determine the patency of the palmar arch. And we do not go over this one in class. We don't practice this one. A lot of this is being done now by physicians in the doctor's office, and they're really not relying on us to complete Allen's tests any longer. So if a patient was, let's say, going to open heart surgery and they needed to harvest the patient's radial artery to use as a bypass, they would call upon us possibly to complete an Allen's test to make sure that if they remove that radial artery, the patient still has a complete palmar arch and will get good blood flow to their thumb and pointer finger, okay, which is normally supplied by the radial artery. So that's kind of in a nutshell what an Allen's test is. And like I said, you may be called upon to do one in clinic, but they are becoming more rare that we are actually completing a test for that. A lot of them are just being done by the physician. And then real briefly, I want to talk about radial artery mapping. I mentioned it just a little bit ago. But sometimes when the patient doesn't have any usable vessels in their legs to harvest for some sort of bypass, they can actually take the radial artery and use it as well. Seems kind of odd, right? But you may be called upon to do a mapping of this. And what we mean by that is we check for the patency. So we look at it in grayscale, we turn on color, make sure there's good blood flow going through there. We don't want a vessel that is heavily diseased or anything like that to use for bypass. You'll also measure the radial artery, proximal, mid, and distal to give the surgeon dimensions of the vessel. So two things that may be used for a radial artery mapping. The patient may undergo CABG, okay, which stands for coronary artery bypass graft. Coronary artery bypass graft, or CABG. Now, basically, this is open heart surgery. This is open heart surgery where they do, a triple or a quadruple bypass. If they don't have usable vessels in the legs, like the great saphenous that I think we talked about on week 1, then they may use the radial artery for this CABG procedure. Another thing is an arterial venous fistula, or AVF, arterial venous fistula. You may be called upon to map if the patient doesn't, again, have usable vessels in the legs or the arms. They may use the radial artery for, creation of the fistula. So again, I would say this is a pretty rare study, not one we do very often with the radial artery mapping. It's relatively simple, quick and easy, and like I said, typically it's ordered by an open heart surgeon. In order for a radial artery to be usable, it needs to be at least 2 millimeters big. Okay, so if it's smaller than that, then they would consider it, not a viable option for completing that sort of bypass. So typically greater than 2 millimeters for a radial artery. And lastly, you're going to complete your tech notes. So as always, you're going to document your patient history. What did they have going on? Why were they there? What other symptoms or things do they have? Document all velocities in a chart. So much like the lower extremity, you are going to put all of those velocities you took while doing your imaging study in a chart. You're going to also categorize your waveforms, okay? So you're going to classify them as triphasic, biphasic, or you can use multiphasic, and then monophasic. So you're going to classify your waveforms in both your imaging portion and in your segmental portion, because you took waveforms in your segmental portion as well. Then with your segmental, you'll also want to comment on PVRs. Okay, so these are our pulse volume recordings. And if you remember, these are the ones that the machine kind of does the work for you. So when you're categorizing these, we categorize these a little bit different. We categorize them as normal, mild, moderate, and severe. And we had some of that for lower extremity with the examples of what those different ones would look like. You're going to document any areas with elevated velocities if seen. And then we're also going to calculate a wrist brachial index and a finger brachial index. Now, the machine will typically do this for you, okay? But you're going to want to have those values reported in your tech report as well. Now, typically somewhere around 1 is going to be normal for your wrist brachial index, and your finger brachial index typically around 0.75, 0.8, something like that, and above is going to be considered normal. If you struggled at all during the exam, be sure to document, again, patient body habitus, patient positioning, anything that you feel like, kind of struggled with in your study. So that concludes everything for upper extremity arterial. I hope that you'll find that many of these things are very similar to the lower extremity, so it's not, something different that you're having to learn. We're just doing the same things over and over, but in a different body part in the arms instead of the legs. So good luck with this and keep working hard.